Epidemic, give me numbers. AIDS at its highest in the United States.
I mean, it continues to be high. I don't have all those numbers at the ready, but it
Ballpark.
I don't have them at the ready. I'm not going to guess on numbers.
Comparable to cancer, comparable to diabetes, epidemic, comparable to bird flu.
They're high. They're high.
They're not. I know we don't agree on a whole lot, but you know, we actually have people who are gay, transgender, who agree with me more on politics, who aren't willing to come on the show. So we always respect anyone who's willing to come in here and bang, so to speak, stand in the pocket. Zack, you have been upset on the Twitter with me before for, transphobic, being anti-trans, anti-gay. Tell me what it is that you see as a problem in what I say. The floor is yours if you want to tell conservatives how to get this right.
Sure. Well, you know, there's a lot of misinformation out there, and we can kind of get into some of those specifics. But the bottom line is that trans students need help. Trans people need help. They are one of the most targeted groups for discrimination. They experience really high rates of unemployment and homelessness and poverty as a result of that discrimination. They're denied health care because of that discrimination. And to
how are they denied health care?
Sometimes doctors are transphobic and refuse to give them health care. Some of them because they don't have jobs.
What do you mean they refuse to give them antibiotics for a cold? They refuse to give them flu shots? When you say denied health care, what do you mean? It's important we frame that in.
Well, it can mean a variety of things. It can mean that they don't have insurance because they don't have a job, and so they just can't afford health care, so they don't even get to the doctor. It could be that they don't have a doctor in their community that respects who they are, and so they don't feel comfortable going to that doctor. Without feeling
that's important. I want to make sure we get the language right here, because especially, you know, you've accused me of being ignorant on Twitter, and that's okay, and I respect that you can say that, but that's not accurate to say being denied health care. If they don't have insurance because they don't have a job, or if they don't feel comfortable going to a doctor, they're not being denied health care. So when you say denied health care, that means a doctor proactively denying someone health care, all health care, solely because they're trans. Is that really a common occurrence?
It definitely happens. I mean, if you look at the 2011 National Transgender Discrimination Survey, which is the largest look at what trans people actually experience, there were certainly people who reported experiences like that, where they came out to their doctor as trans and either received no treatment or didn't receive the treatment that they needed.
So in regards specifically to trans, but what if a doctor says, hey, I'll treat you and everything else, but I'm not going to do the hormone replacement therapy. This is an issue I'm not going to touch because the science isn't in, and I don't think it's good for you. Is that considered denying health care?
I think it is, because a lot of the care that they need for their transition is medically necessary. If they can't achieve mental health wellness because they can't access
medically harmful?
Of transition, there's no evidence to suggest that it is.
Well, sure there is.
And that's some of the misinformation that we can get into if you want to. I mean, one of the
stats
I've
got it right here. Let me bring this up because this is important. Now we can get into gray matter and we can talk about how the brain works, but I've got this a pretty empirical analysis here. It is not surprising that the influence of sex hormones in the brain were not limited to hypothalamus, but they're also expressed. So prior to cross-sex hormone treatment, a lot of the studies that I've heard you trot out and people trot out were involved with people after they had gone through the cross-sex hormone treatment. When you eliminate that variable, you see that a male to female transgender, the brain size is exactly in line with other males, and it only changes once you go through cross-sexual hormone replacement therapy. Now, there's a big controversy right now in the medical community just regarding testosterone replacement therapy or growth hormone for injuries. Some people think that's a problem. Going into estrogen, putting it directly into a male, which every study we have would show bad results, cancerous results, is it not within the bounds of reason for a doctor or an establishment like Johns Hopkins, who maybe they're not ignorant, maybe some of them are progressive liberals, and they just say, these are not great results, we've studied it, we don't want to do this right now. We need to wait until the science is in. Is that a possibility?
I mean, I'm not familiar with the studies that you've talked about. I'm familiar with studies that show that there are no consequences for trans people that use cross-hormone therapy, and I'm familiar with many studies that show that there are great benefits to their health and well-being.
I've got it right here. Transsexuals had brain volumes in agreement with their sex at birth. The intracranial volume and the hypothalamus volume of males were larger than females, irresponsive of condition of transsexualism. This supports the notion that the brain volume changes in transsexuals are related to cross-sex hormone treatment and do not reflect pre-existent differences in brain volume between transsexuals and comparisons. So, isn't it possible for a doctor to take this? This comes from medical journals to say, well, we know the changes occur after the sex hormone replacement therapy. And we know that that can be bad, so let's hold off. Or is that doctor ignorant? Because I want to make sure we frame in the language, because there are a lot of doctors out there who would probably agree with you, except for when it comes to the medicine.
I mean, that's not the mainstream understanding whatsoever. You have one study that has one particular factual. No, it's not what the American Medical Association says. It's not what the American Psychiatric Association says. You have one doctor, Paul McHugh at Johns Hopkins, who has many anti-LGBT biases.
Well, hold on a second. You talked about doctors. Now you've gone from what's mainstream. You said I've not seen those, so we've provided you with empirical data studies. You said, well, I've not seen that, and then you go to some doctors say this, and we could both agree, right? There's a political motivation behind a ton of what happens in the medical industry. I'm sure we're on board with that. Probably with big pharmaceuticals, probably with medical boards. We'd agree on that when it comes to a lot of things. So now we've denied the data and the statistics, and we've gone to what one doctor has said.
I'm on board with medical organizations actually using, I'm only familiar with one doctor who advocates against cross-hormone therapy and transitioning for trans people, and that's Paul McHugh at Johns Hopkins, and that's where Johns Hopkins gets that reputation. So I'm not familiar with the study that you cited. I'm not sure I understand what it is you're concluding from that study, except something about how brains change. But what I know is
the difference is I've not concluded something.
That shows that. Excuse me, I'd like to finish.
It's not fair. I can't let you get away with that, though, and say I only know one doctor. That's not accurate, Zach. There's more than one doctor on planet Earth who thinks that injecting estrogen into a man or abnormal levels of testosterone into a woman could be bad. The only point I'm making here is that doesn't mean that this sector of the medical industry or America or the world means they're bigoted or ignorant. You're drawing a conclusion. I'm not. I'm saying, is it within the bounds of reason that a doctor may not want to treat that because the science isn't in, and it doesn't necessarily make them a transphobic bigot? It's a simple question.
There's two pieces to that.
Okay.
One is I'm highly suspicious of any doctor that draws their own conclusions based on things that they can find in certain studies when the rest of the industry has found a different approach is necessary. If everyone agrees in the psychiatric community, or at least an overwhelming majority, and everyone agrees in the medical community that the best way to help trans people achieve wellness is to support them in their transitions, then it doesn't matter to me if there's a couple doctors who disagree, and it would make me question their motivation.
There isn't a couple doctors, and there is not unanimous agreement. That's just not accurate, Zach. We can have an honest conversation, but that's not accurate. You can't come on and say that and say there might be a couple doctors. It's not accurate. It's not honest to say. They're not entirely unanimous. And even if that were the case, consensus isn't an agreement because they were unanimous that it was a disorder not long ago. Why is that not okay? Because it's changed?
Because that's how science works. We learn more and we do what makes the most sense based on the evidence that comes in. The reason it's moved is because we've got more evidence that supporting trans people in their transition is what supports their well-being.
You just discounted the evidence that I brought up and said I've not heard of it and I only know of one doctor. That's not science.
But what I'm saying is that does not represent the consensus. You finding an exception to the rule does not disprove the rule.
If a doctor says, I want to get back to the question because you're getting up. If a doctor, because you said denied health care, and you use this and you call people bigots and you call them ignorant. If a doctor who is treating someone and still will treat that person as any other patient but says, I'm not going to do hormone replacement therapy or go down that path, but I will treat you as a patient, are you filing that under denying health care? I just want to be clear.
If the standards of healthcare say that supporting trans people in their transition is the best way to support them, and they are rejecting those standards, we do have them, and those are the standards that they reject, then yeah, I would say that there's a problem that's denial of treatment. Okay,
well, I just want to make clear for the audience listening, because when Zack Ford says transgender people are being denied treatment in record numbers, what he is saying is if every single doctor does not give them any kind of transition treatment they want, that should be considered denial of health care. And the same token, I can't get a lot of treatments that I want that are electable from my doctor. So I just want to make sure people understand that, because you throw these stats
out. About them. Well, you just threw the word elective out. The problem is that it's not elective. The problem is that we know from the research that supporting trans people in their transition is what supports their mental health wellness. And so if they're experiencing gender dysphoria, if they're experiencing any sort of depression or suicidal thinking as a result of not being able to correct that dysphoria, then rejecting them the treatment that helps them overcome that is problematic.
Oh gosh, we use that word problematic. Well, the suicide rates don't get much better.
They do, because you're using the Swedish study that doesn't actually say what everybody says it was. I know Dr. Boniface used it on your show last week, and if you look at the Swedish study, it did find that there were high rates of suicide among people who had had surgery, but it didn't compare them against other transgender people. The researcher of that study has publicly said that to use her research to suggest that suicide rates go up after surgery is
no, I didn't say suicide rates went up. I didn't say suicide rates went up. I said the suicide rates don't get much better. And the suicide rates, if you look at after surgery, is still astronomically much higher than the general populace or gay Americans, right?
Right. But that has nothing to do with surgery. That has to do with the discrimination they experience. I mean,
would it maybe have to do with, okay, but hold on a second. Discrimination, hold on. You said that, again, you're stating something. We got to stay on task here, Zach, with when you state a fact, we need to, okay, let's define that. You say the discrimination. Sure. So do you believe that transsexuals, transgender, the term that we're using, I guess, now to be more umbrella, do you believe they face worse discrimination than black American slaves? People in the Holocaust? What about black people in the 60s who didn't have the right to vote? What about gay Americans in the 80s? You believe that they're treated multiple times worse because their suicide rates are worse than black American slaves?
It doesn't matter how any of those other groups are treated. What matters is that we have a problem. No, it doesn't.
It does matter because you said it's a result of discrimination. But now when we eliminate, okay, here are other groups who were clearly much more violently discriminated against than transgenders, nowhere near anywhere else on the map. That kind of a suicide rate, whether it's pre or post surgery, the only other place you find that would be people with severe psychiatric conditions.
But the research that we have shows that the people with the highest tendency to attempt suicide are those who have experienced the highest rates of discrimination and the highest rates of family rejection. So you can think whatever you want. I'm not trying to compare them to any other group. I'm simply saying that the research we have shows that it's not surgery that impacts their suicide rate one way or the other. It's the experience that they have in society where they can't get jobs, they can't find housing, and of course there's going to be consequences that come with that. Okay, so the suicide rate isn't impacted by surgery one way or the other. I just want to make sure you just said that. I'm saying that because we agree on that. It does not make it worse. It doesn't make it worse, but it doesn't make it better. Is that a fair middle ground? No, I don't think that's true either, because I think that the research shows that having surgery and going through transition actually helps improve their wellness. That's what the researcher. You just said the opposite. You said it doesn't affect it one way or the other. Okay, let's go with that. Let's assume that it's minute. And even after, can we agree on this middle ground? Even after surgery, the suicide rate is still astronomically higher than these other groups who have faced discrimination that I just named. Yes? Is that fair? It's certainly higher than the general public. And that's no, than other groups who've been discriminated against, whether they're gay. I don't have data about what the suicide rate was among slaves hundreds of years ago. Okay, let's use suicide rates black Americans in the 60s. What the suicide rates. Okay, well, I just want to make sure we can find, I'm trying to find some middle ground there, and you're kind of going back and forth. So I just want to make sure there's no way for a doctor, in any case, anyone in the medical community, doctor, who sees the issue as anything other than full transition, surgery, hormone replacement therapy, science is in, without being denying care or transphobic, correct? Well, I would qualify that only to say that different patients have different needs, but yes, there are standards of care for trans people, and if the doctor doesn't follow them, then they're denying them the care that they deserve. This is important, just for people listening. One thing I do find, so you are, and we wanted to have Chad Felix Green on, and we wanted to respect your wishes because you and him have gone back and forth on Twitter, and I know you didn't want to. Something that I feel like everyone should agree on. So no one has given me a convincing argument here, and I'm willing to hear it. Maybe you can, because I know you've made this a big part of your platform. You're against exposure laws, disclosure laws. For those who are listening, if someone has HIV, basic laws that say if you have HIV, AIDS, you need to disclose it to a partner before you have sex, otherwise you should be liable. You're against that. Let me hear a convincing argument as to why. Well, let me ask the question, at least rhetorically, of why having the law is good. The laws that we have on the books criminalizing the transmission of HIV without disclosure date back to very early in the epidemic when we didn't know as much about it. Right. And what we now know is that those laws actually hurt our efforts to stop the epidemic. So the question is, do you want to actually minimize how much HIV is spread, or do you want this sort of petty feeling of justice against people who already have HIV and have to struggle with that? Interesting you should bring up epidemic or petty struggle. Epidemic, give me numbers. AIDS at its highest in the United States. I mean, it continues to be high. I don't have all those numbers at the ready, but ballpark. I don't have them at the ready. I'm not going to guess on numbers. Comparable to cancer, comparable to diabetes, epidemic, comparable to bird flu. High. They're high. They're not. It's still a problem. They're not. The epidemic hasn't ended. They're not. They've never been high. How high are they outside of the gay community? Well, let's be honest here. According to the CDC. They're high in the gay community. That
Outside of the gay
me.
community, what are the chances of what are the numbers outside of the gay community of someone getting AIDS? Said epidemic. Epidemic is something that is measurable. Or pandemic, if you want to go further, with SARS at the Toronto airport. I remember they were throwing that around. Canada was the only country to still get SARS. We screwed that one up.
Canada.
You say epidemic, you need to substantiate that.
My use of the word epidemic means that it's continually spreading, not that it's representative of any sort of numbers. I don't really care who's vulnerable to it and who isn't. There are a lot of people still getting it, and that's a problem.
Okay. Well, it's almost it's an entirely preventable disease in the United States.
It sure is.
Right. Particularly with disclosure laws.
No, those aren't helping at all.
They don't help at all.
No, what helps is if people get tested, and if they test positive, if they get on treatment so that they can reduce their viral load to undetectable levels, that makes it nearly impossible for them to transmit the virus.
Nearly impossible.
It's never happened with people having undetectable viral loads transmitting the virus. It's virtually impossible.
Why would you say nearly or virtually if it's impossible?
Because just because science hasn't found an example of it happening, it doesn't mean it can't happen. But the research.
Well, without
shows
disclosure laws, it would be very hard to know what someone's viral load was. You and I both know that, right? If someone's not disclosing it, you can't possibly know what kind of treatment where their viral load is or where you're getting the HIV.
But the problem, Stephen, is that the disclosure laws actually scare people out of getting tested. And so there are a lot of people who don't know their status. And one of the reasons is because they're afraid if they know their status and they're positive, then they're opening themselves up to liability. So the disclosure laws are actually discouraging people from finding out their status and discouraging people from getting tested and then discouraging people from getting treatment.
We've gone, but hold on, what about the right of the person? What about the right of the person who's having sex with another man who doesn't want to get HIV or AIDS? I'm still not hearing why it's not that person's right to know, for it to be disclosed. Again, I'm just want to hear this and charter schools. School choice are two issues on which I've never heard a convincing argument, so I want to give you one last pass, because that one didn't cut the mustard.
Well, there's certainly, I'm not going to disagree that sharing your status is proper etiquette, but the issue is whether or not it becomes a legal issue. And where I stand is, what about the responsibility of the person to ask the question? You know, if a person lies about their status when they're asked about it, that's very different than simply not disclosing. Because if a person is, using a condom and they're undetectable, they're not posing a risk to the other person. So why are you imposing a criminal liability on them? It's just stigmatizing.
Because as long as that is not entirely 100% impossible, if there's a chance of you giving a potentially life-threatening virus, disease to somebody, you should disclose it. That person has a right to know.
Well, one, it's not life-threatening anymore, so...
You just said it was an epidemic. As far as spread. So, okay, what are the death rates then? My point is, right, it's one of the single most funded diseases out there. If you're going to say epidemic, what are the numbers and what are the death rates? If you're saying it's really not that common, it's entirely preventable, and it's not deadly, why are we going around screaming that it's an epidemic?
I'm saying that it's still very commonly spread. I'm saying that
but it's not, and we know it's not. That's why you don't want to bring up the numbers. That's why AIDS is always brought up as a percentage and not actual numbers. It is minuscule. It is incredibly unlikely.
But what I'm saying is that the transmission rates have not gone down. So you can quibble about how many people are affected by it. That's fine. But the transmission rates have not gone down. So the size of the problem has not gone down. And yes, we've improved treatment that's helping people do better, but it's not necessarily changing the fact that we need to get them on treatment so that they don't have the problems that people used to have when we didn't have
So why do you
treatments.
apply personal responsibility to the person who may be infected with HIV to ask, but you don't apply the personal responsibility to simply go get their checkups and get treated? Why is one responsible for someone else disclosing and that one person isn't responsible for his own sexual misconduct?
I think we're all responsible for ourselves and the decisions that we make with our bodies. Where I have the problem is where we pass a law that criminalizes people in a way that doesn't actually help end the
No, it doesn't criminalize people, because you've written that. I have it up on my screen. Laws that criminalize HIV, you wrote, in 33 states. Just to be clear, HIV is not criminalized in any state. It is having sex with someone when you have HIV and not telling them. That is the illegal act. So I just want to make sure we define the language, because I think that's the only way we can have these honest conversations. Hey, if you like this clip, it's taken from the full-length podcast every week. You can click that box down below to watch the full free video cast, or subscribe on iTunes to watch on the go. Click my face to go to louderwithcrowder.com, where we write plenty of articles, columns, and upset those who are easily triggered. Or click below me. There's some other video down there. I don't know what it is yet. Not Gay Jared is going to toss. It's probably going to be something ambiguous but uncomfortable.